neoadjuvant therapy is where more to the secondary endpoint to get a negative margin, lymph node negative, and increasing disease-free survival. If I talk about one of the most important, most famous clinical trials, this is a PRIOPANC trial, which was a randomized phase 3 trial. It was a Dutch trial comparing a patient with borderline unresectable pancreatic carcinoma. One group were going directly to upfront surgery. The other were assigned to receive chemoradiotherapy, then reassessment, then for surgery. The primary endpoint, this subgroup, the characteristic of the patients, both resectable and borderline resectable, were included in the study. If you see here, the median overall survival was 17.6 months for those who received preoperative chemoradiation, while it was 13.2 months for those who go to upfront surgery. But if you see here, the p-value is non-significant. So there was non-significant survival benefit. While in the secondary endpoint, the disease-free survival and R0 rate was much higher with those patients who received neoadjuvant therapy than those who underwent upfront surgery. So in this trial, PRIOPANC trial, the preoperative chemoradiation for resectable or borderline resectable pancreatic cancer didn't show significant overall survival benefit in all the group. Although the outcome of secondary endpoint and predefined subgroup analysis suggests an advantage toward the neoadjuvant therapy. But of course, additional trials were needed. Another trial on the borderline resectable disease, which is a Korean trial. This trial also compared the patient borderline resectable. The one group were assigned to receive concurrent chemoradiation. The other group also received going to surgery without neoadjuvant therapy. But this trial did show a significant increase in the overall survival for patients that received the concurrent chemoradiation. This trial was not like the other one. It did show the median overall survival benefit for those who received neoadjuvant chemoradiation. The overall survival was about 21 months comparing to 12 months for those who didn't receive the neoadjuvant chemoradiation. But this trial concluded only borderline resectable, unlike the other one that were also resectable were also included in the study. Until now, all the guidelines are accepting the neoadjuvant therapy for borderline resectable, but the main controversy is here in the resectable. What about 2 minutes? In the resectable group. The resectable, do this group also get benefit from the neoadjuvant therapy or no? What is the advantage? I just talked about the advantages in the borderline resectable. It is the same, but some point to remember that, as we said, that one of the aim of the neoadjuvant is so that the patient can get all the planned chemotherapy, because most of the patients, they cannot, around 50%, they will not initiate adjuvant chemotherapy because of the decreasing in the performance status, because of the decreasing in the nutritional status of the patient. And to manage micrometastasis, of course, to know the biological behavior of the tumor. One point here to be mentioned, this trial showed an association between pancreatic fistula and long-term survival in the era of neoadjuvant chemotherapy. This trial showed that those patients who receive neoadjuvant chemotherapy has 3.6-fold decrease in the postoperative fistula formation, and which was this group who didn't have fistula had a better long-term survival than those who go to upfront surgery. Of course, one of the other point of neoadjuvant therapy, this area have a good blood supply before the surgery, so it's well oxygenated. It will be more radio sensitive, so better response. What are the evidence in resectable pancreatic carcinoma? The NCCN guideline, we have two options. Here, either the patient go directly to surgery or for neoadjuvant therapy, but in resectable with high-risk feature. Who are high-risk feature? Who have very high CA19, large primary tumor, large lymph node, symptomatic patient who have extreme weight loss and extreme pain. These patients, even if it is resectable, they better to receive neoadjuvant therapy, chemo plus minus radiotherapy. The pre-bank trial, when there was a subgroup analysis, it didn't show any survival benefit in resectable cancer. But another important trial in resectable pancreatic cancer is JSAP trial, which was a Japanese trial comparing a group to upfront surgery or receiving chemotherapy in GIMZAR S1. This trial also did show a good overall survival of neoadjuvant chemotherapy comparing to upfront surgery in resectable pancreatic carcinoma. So this trial, the PRIOPANC said no, there is no survival benefit, but PACT 15 also, it was an Italian trial with JSAP, said yes, there is overall survival benefit of chemotherapy, neoadjuvant therapy in patients with resectable pancreatic carcinoma. But the good news is here, this ongoing trial, why we are expecting to have a better outcome, because these ongoing trials are using the newest protocols like modified FOLFIRINOX or nab-paclitaxel GIMDAR. We are expecting to have even a better survival than before. Disadvantages are chemotherapy toxicity, progression of chemo on the neoadjuvant, and one of the points also here, unfortunately, we have a low rate of complete pathological or radiological response in patients with pancreatic carcinoma. I will conclude my talk with this slide. Most of the 50% of pancreatic carcinoma, unfortunately, they are metastatic or inoperable. Resectable, which is about 10 to 50%. They may either go to upfront surgery or may benefit from the neoadjuvant therapy. Then surgery borderline and locally advanced, better to receive neoadjuvant therapy than for surgery, and thank you.
Thank you, Dr. Arawaz. Excellent presentation. I have two comments. First one regarding Professor Boschler. I have the privilege working with him. He is visiting our center frequently. He is working out of the guidelines. He is operating on locally advanced pancreatic cancer, even with vascular invasion, and he is resecting the tumor and grafting the vessel. The second point, and even in metastatic disease, if we are giving chemotherapy and tumor marker drop to normal, he operating on them, removing the primary tumor. This is one. The other point regarding chemoradiotherapy as neoadjuvant. The American people believe in that they are giving chemoradiotherapy, but mostly all the data are negative. The European not believing in that and not giving chemoradiotherapy in pancreatic cancer.
Yes,
thank you.
Thank you. That's question.
Dr. Nian.
Okay. The last presentation will be...
No.
Yeah,
before the last.
Before
the last. Dr. Nian.
Okay.
Yeah.
Will be presented by Dr. Nian. She is a radiation oncology, and her presentation will be neoadjuvant radiotherapy and rectal cancer.
Thank you, Mr. Chairman, for the introduction. Good afternoon, everyone. My topic about the total neoadjuvant therapy and rectal cancer. But before I start starting my topic, I will topic about the MRI staging in critical, as there is heterogeneity with the stage 2 and 3 rectal cancer, and it's critical for our decision making. The location of the tumor, is it in the upper rectum, mid, or lower rectum? If it is in the lower rectum, if there is any invasion of the anal sphincter, external or internal anal sphincter. If it is in the upper rectum, if there is any invasion of the rectosigmoid junction, if it is above peritoneal reflection or below peritoneal reflection. And MRT category also very important, especially for the T3. T3C, when there is more than 5 millimeter extension beyond the muscularis propria, which is associated with a worse overall survival. Also present or absent of the extramural vascular invasion, very critical, as a baseline or after chemoradiotherapy associated with the worse overall survival and disease-free survival. Also presence of lateral lymph node associated with the more local regional recurrence after chemoradiotherapy. In the historic rectal cancer trial, we have so many trials comparing the non-TME with the short-course radiotherapy or TME with the short-course radiotherapy showing improving in the local control. In the German trial, comparing the preoperative long-course chemo-RT with the long-course chemo-RT, that's also showing improvement in the local control, decreasing acute and late toxicity, and more sphincter preservation. But the problem in the historic trial is the distant recurrence rate, it's about 30%. That's why they are thinking of about new treatment trend in the rectal cancer, which is total neoadjuvant therapy. What is the advantage of the total neoadjuvant therapy? Is the chemotherapy compliance, as the patient managed by operation need more time for recovery, and starting the systemic therapy associated with a decreased distant recurrence for patients with micrometastatic disease, and improved rate of pathological fracture, pathological response, and earlier reversal of diverging ileostomy. And I will talk about, if I have a time, the ongoing trial on the non-operative management, even in the locally advanced disease, and or selective use of radiotherapy, or omission of chemo and RT in immunotherapy in MSH high tumor. When to give neoadjuvant, total neoadjuvant therapy, if the patient have locally advanced disease, or the patient in high risk for local regional recurrence or distant recurrence, if the patient have mesorectal facial invasion or N2 disease or lateral lymph node, or we can use it as a part of the organ preservation. What is the locally advanced disease in rectal cancer? According to the ISMO risk classification, they are dividing to very early, moderate, intermediate locally advanced, very locally advanced, or advanced disease. From the T3C and D, they can categorize as a locally advanced disease, or even some case of T3A and B in the mid and high rectum without risk feature of local or distant metastatic disease. We have a different approach for the total neoadjuvant therapy, comparing with the standard chemo radiotherapy, either using short course radiotherapy 5 fraction, followed by chemotherapy and then TME, or starting with the induction chemotherapy, then long course radiotherapy, then TME, or starting with the induction chemotherapy, or starting with the long course chemo-RT, then chemotherapy, then TME. According to the published randomized trial on the TNT, we have 3 on the short course radiotherapy and 3 on the long course. Among the short course radiotherapy, Rabito trial revealing better disease-free survival, and also the French trial among the long course chemo-RT showing better disease-free survival. In the Rapido trial, the inclusion criteria is the T4A and B, N2 disease, lateral lymph node, and mesorectal facial involvement. The arm between the standard chemo-RT, then surgery within 8 weeks, then chemotherapy optional, and the second arm is short course radiotherapy, then consolidative chemo, either 6-course or capox or 9-FOLFOX, then surgery within 2 and 4 weeks. The results of the Rapido trial, the 5 years disease-related treatment failure and distant metastatic rate decreased by 7%, but the local failure in the 3 years is equivocal. But the problem is in the 5 years, the local failure in the Rapido trial, 12% compared to the 8% in the concomitant chemo-RT. But still, the disease-related treatment failure is better, and by 7%. As showing in the first 3 years, the disease-free survival is, the local failure is equivocal. After 3 years, it's more. Among the short-course radiotherapy, the Rapido trial showing more pathological complete response as giving more chemotherapy. This is the comparison between the short-course trial as giving more chemotherapy associated with a more pathological complete response. And delay surgery also associated with a more YP pathological complete response. And in this trial, when doing surgery in the 4 to 8 weeks after short-course radiotherapy, most of the case in the delay surgery have Y pathological stage 1. And the rate of post-operative complication also less in the delay surgery compared to the immediate surgery. Sorry. In the approach trial, this is a trial on the long course radiotherapy. The arm between the standard chemo-RT and the other arm is the induction chemotherapy, then long course chemo-RT and TME. This trial also revealing more disease-free survival and distant metastatic rate, but the overall survival is still, there is no difference. In the German trial and OPERA trial, they are comparing consolidative chemo with the induction chemotherapy when using the long course chemo-RT. In the consolidative chemo, when starting with the chemo-RT, then chemo, the rate of pathological complete response is more. And the OPERA trial, this is the trial on the non-operative management even in the locally advanced disease, including stage 2 and 3, comparing the concomitant chemo-RT with the consolidative chemo, or starting with the induction chemo, then long course of chemo-RT, the rate of non-operative management more in the consolidative chemotherapy. This is the results of OPERA trial. The distant metastatic rate and disease-free survival is better, and the TME-free survival and actual TME is better in this trial. Also, the complete response more in the consolidative than in the induction. Also, in the long course chemo-RT, also using more chemotherapy associated with a more pathological complete response. So, giving short course radiotherapy or long course radiotherapy in the meta-analysis of randomized and randomized control trial, showing there is no overall survival difference and there is no local recurrence difference between short course and long course radiotherapy. Giving the TNT or standard chemo-RT, the meta-analysis showing that there is less disease-related treatment failure in the TNT, and but the overall survival is equivocal between the two arms. And also, as I say in the historic trial of standard chemo-RT, we have more distant metastatic, but in the TNT trial, the rate of distant metastatic decreased by 7%. In the meta-analysis of, okay, I will try my best. In the non-operative trial, the meta-analysis showing that there is no difference in the oncological outcome. Ongoing trial on the non-operative management, even in the locally advanced disease, in the Janus rectal cancer trial and in the large ongoing trial on the German trial, that comparing the short course with the long course, followed by adjuvant chemotherapy, and if the patient have complete clinical response, they put him on the watchful wait. We are very cautious to see the results of this trial. Is it safe to omit radiotherapy? We have so many trials in the rectal cancer, including mercury, quicksilver, and these all trials in the early stage of radiotherapy, they can omit radiation, but the large ongoing trial is the Alliance Prospect trial. This trial giving chemotherapy 6 cycle of FOLFOX, then reassessment of the patient. If the regression less than 20% giving chemo-RT, but if the regression more than 20%, they proceed with the TME and then giving another 6 cycle of chemotherapy. The results of this trial published in the last month. There is non-inferiority in the disease-free survival and local recurrence, but the problem is in the toxicity. They have more grade 3 and more toxicity as they are using 12 course of chemotherapy instead of 6 cycle of chemotherapy. The problem in the neuropathy present in 83% of the case compared to 17% in the standard arm. I can omit this. The future treatment strategy, as I mentioned, based on the MRI criteria, is the omission of radiotherapy in the Prospect trial, or according to the Opera and Janus and German trial, intensify radiotherapy and non-operative management. In conclusion, we have better disease-free survival in 2 out of 4 randomized trials comparing the TNT with the standard chemo-RT, and there is no difference in the disease-free survival comparing induction chemotherapy with the consolidative chemotherapy when using long-course chemo-RT. And there is no survival benefit in any of the trial. TNT is beneficial to achieve more complete response, and the consolidative chemo better than the induction in the complete response, and increasing response rate with increasing number of the cycle of chemotherapy. And thank you.
Thank you, Dr. Nian. Now, the last topic is for Dr. Hero and Dr. Hiwa. The subject is about the third space endoscopy SDER case report. You have only 10 minutes, Dr. Hero.
It can be Okay. Thanks for the chair committee. Good afternoon, dear teachers and colleagues. I'll be very short presentation about third space endoscopy. And our lecture is supported by the AstraZeneca company. Not working. Okay, so in the past 70 years, the endoscopy has a crucial impact on the practice and management of GI diseases, and it represents not only standard of care for the diagnosis and also for the treatment of the GI pathologies. The GI interventions, which are confined to the GI lumen, it is called first space endoscopy. And it started in the 1969, which Dr. Shinya did the first endoluminal intervention by doing endoscopic polypectomy. And from that time, there has been a tremendous progress in the practice of GI interventions. Okay, so as we mentioned, the first phase is the intervention which are taken inside the GI lumens. Some resources mention that the second phase is in the peritoneal and thoracic cavity, while some resources mention that it is cholangioscopy and pancreatoscopy, which is regarded as the second phase endoscopy. And what we're focusing now on is the third phase, or submucosal space, which is done by doing an incision, creating a mucosal flap, and working in a tunnel or under the mucosa and doing certain interventions. Recently, there has been fourth space endoscopy, which means endoscopic subserosal dissection, and there are every day new interventions in the GIT. So the idea of submucosal tunneling has been described first in a porcine model by Sumiyama et al. In 2007. After that, after 1 year, Dr. Inouye and his colleagues performed the first human peroral endoscopic myotomy for management of achalasia, and this was regarded as a revolution in the era of third space endoscopy, and it is the archetype of third space endoscopy, because after that there has been many other types of endoscopic tunneling, like as we mentioned, POIT or STER, which we talk about it. We have GPOIM or pyloromyotomy. We have FPOIM, POIM with fund duplication. We have ZPOIM or submucosal tunneling and endoscopic septal division. We have DPOIM for management of esophageal diverticulum. We have peroral endoscopic treatment of esophageal stricture with restoration of the lumen, which is POITRE. And we have PRIM, which is done in the first time by Amal Bopaya in 2017 for management of Hirschsprung disease, which is called perrectal endoscopic myotomy. So these all procedures are originated from the POIM, which is done first by Professor Inouye. And this is nicely discussed by Dr. Amr. I will not go into that detail. So what are the tools which we need for third space endoscopy? We need, of course, endoscope with distal cap. We need a good electrosurgical generator. We need carbon dioxide, which is very essential because the procedures take a long period of time. We need low flow gas tube or extra low flow gas tube. We need electrosurgical knives, special tools for this incision and dissection. We need coagulation forceps for hemostasis. We need endoscopic flushing pump. And we, of course, for closure, we need endoclips. These are different types of the distal cap, the standard one, the short ST, and the ST hood, and different type of knives which we perform this procedure with. And what is POIT or STER? POIT is peroral endoscopic tunneling and excision of tumor, or submucosal tunneling and excision and endoscopic resection of tumor. The same principle, but two different names, because the Japanese prefer to call it POIT, which was done first in 2012 again by Professor Inouye, which was published in the Endoscopy Journal. And at the same year, Zhu MD et al. Did submucosal tunneling and endoscopic resection, which is published in the GIE in the same year. So the idea is the same, incision of the mucosa, creating a tunnel in the submucosa, and doing resection of subepithelial lesion in the esophagus, cardia, and recently in the rectum also. So as we mentioned, it is for management of subepithelial lesions, like, for example, stromal cyst or stromal tumor, leiomyoma, lipoma, schwannoma, and ectopic pancreas, of course, when it is symptomatic and need intervention. So this is how we do the tunneling and endoscopic resection. And since the November of 2022, we did about 5 cases of STER with our team, Dr. Hiwa and Dr. Marwan. And this case, which was now presented by Dr. Hiwa, is somewhat a challenging case because the size of the lesion was slightly larger than what's expected to be resected by STER procedure. So now the case will be presented by Dr. Hiwa. Thank you very much.
Please.
Thank you very much, Mr. Chairman. Dr. Hero, this patient actually is a 75-year-old male from Rania. He presented with long-standing history of dysphagia, mainly for solid food, and no history of alarming symptom or sign. EGD or GD revealed that the large subepithelial lesion about 3 to 4 centimeter in the mid-esophagus, about 28 to 33 centimeter from the incisor, and the CT scan and endoscopic ultrasound radial. We did only radial endoscopic ultrasound because we decided to do tunneling technique, so FNB not performed, because we try to avoid any adhesion or complication of the FNB in order to make the procedure easy. By CT scan and EUS was suggestive of leiomyoma. And video, please. So you can see that the lesion is located from an anterior part of the mid-esophagus, which is a big lesion, not straight forward, not straight lesion. You see, this is a leiomyoma. This is a subepithelial lesion with normal overlying mucosa, slightly vascular. NBR revealed normal superficial vascular and mucosal pattern, not any evidence of malignant epithelial lesion. And we try to use TXI mode from Olympus, which is very good for characterization of the superficial vascularity. Usually for stair technique, we made about 5 centimeter above the lesion entrance, just like a peroral endoscopic myotomy, which usually 1.5 to 2 centimeter longitudinal incision. Why we do longitudinal incision? Because for the closure, longitudinal incision much easier and transverse difficult for closure. So we want to avoid triangular incision. We made trimming of the submucosa in order to cutting the muscularis mucosa fibers in order to enter into the space. We used Olympus scope with standard Olympus cup and triangular tip knife from the Olympus also. This is a submucosal space. And this is a knife from triangular tip knife from Olympus, of course. This is a crucial step because we want to avoid injury of the muscle in order to avoid development of subcutaneous emphysema. This is a fiber of the submucosa. Now we will create a tunnel by injection of water in order to separate muscularis mucosa from the muscle. Our enemy in the third space endoscopy is injury of the muscle, injury of mucosa, but injury of the muscle not important. This is a big leiomyoma. You can see that it appear what-shaped lesion arising from superficial muscle layer, not deep muscle layer of the esophagus. This is a mucosa, and this space submucosa, and this is a lesion arising from the muscularis propria. Every now and then we have to come out in order to check for any injury of the mucosa, and we have to control the bleeding by co-grasper. We are using monopolar coagulation, although there are now bipolar probe, which is less cautery. And we made trimming. We have to circumferentially, we have to release the leiomyoma from the muscle, and because it's a benign pathology, we don't afraid from safety margin, especially for leiomyoma. This is a lesion, and this is muscularis propria of the esophagus. Very demanding procedure, sometimes take more than 2 to 3 hours, especially for our, as you are beginner. This is a heart, and this is mediastinum. You can see that we are making a big defect in the esophageal wall by separating the leiomyoma, which is a very big leiomyoma. The last pedicle of the lesion. We try to bring the lesion after separation as one piece, but unfortunately, because of risk of perforation and increasing the size of the entry point, so we decided to cut the lesion by a snare in two pieces in order to make extraction of the leiomyoma easy, because it's a benign lesion and we don't need embolic resection for the histopathology. So the lesion is separated into two parts. And once cut it in two parts, then we extracted both particle of the arm of the leiomyoma. You can see it cut it in two parts. After complete release from the muscularis propria, and then you can see after release of this is the defect area, complete clearance. There is no any residual tumor. There's a heart. There's a mucosal defect. We made some injury by cautery and by release extraction of the leiomyoma. So after finishing the complete dissection and ensuring hemostasis, we have to close all the mucosal defects. So we applied 2 clips on the opposite side to close this defect area, and this one. And then we close the longitudinal defect by about 5 to 6 clips using 16 millimeter hemoclip from Microtech. The patient kept on nil by mouth for 24 to 48 hours with a smooth postoperative face with no sign of mediastinus, no any leak. And this procedure done about 3 months ago. Now he is very well. There is no any recurrence of dysphagia with smooth postoperative care. And after the extraction, you can see the lesion about 5 centimeters. And the histopathology, including immunohistochemical stain, revealed that it is leiomyoma. This is stain, normal stain, and this is after immunohistochemical staining revealed that it's positive for actin and desmin, with negative marker for gastrointestinal stromal tumor. This is a histopathological report by our pathologist, Dr. Emin, that revealed that there is bundles of spindle cell arranged in intersecting bundles with a wiring pattern with multiple foci of calcification. There is no mitosis or necrosis. Smooth muscle actin positive. Strongly positive fused cytoplasmic staining pattern. Desmin positive. DOGI negative and CD170 negative, ruling out gastrointestinal stromal tumor. And thank you very much.
Thank you, Dr. Hiwa, for your nice presentations. And now the floor is open for the discussion.
Please, the speakers.
Baran. Two questions for each person. Two questions for each person.
Okay. Question.
Okay.
تعال استريح تعال استريح اقعد ايوه
شنو ما شاء الله women in gastroenterology.
Okay, there is question from here.
Yeah, okay.
Okay, go on.
Only 2 short questions. One for Dr. Haja. It is very nice if you can help the patient to be treated to change the place of the patient to curation, especially for the colorectal peritoneal cavity or parietal peritoneum or even visceral peritoneum. It is nice to treat them. But how we can diagnose them? Because most of the micrometastases, especially few millimeters, even can be missed on PET scan, even can be missed on MRI, on CT scan, and even can be missed by laparoscopy also, especially those small nodules located between the bowel loops in the some parts of the peritoneum that cannot be seen on laparoscopy. The second question for Dr. Hiwa. Operation you did these clips for the suturing. They are temporary or permanent clips. You can remove it after a while. Thank you.
Okay, thank you very much for your question. Really, if in order to diagnose primary peritoneal carcinomatosis, the most important and most sensitive modality is the MRI. So MRI is the modality of choice that they should be used for the accurate diagnosis of the peritoneal carcinomatosis. As I told you, patients with the mucinous carcinoma of the colon, they are not sensitive and not easily detected by PET-CT. So even PET-CT is not helpful in this situation. And the majority of this patient, they should undergo diagnostic laparoscopy because we need a PCI score. So PCI score depending on the diagnostic laparoscopy in order to define the size of each metastatic nodule and later on the distribution among the already divided sectors of the abdomen and small bowel.
Yeah, just comment on what Dr. Haja is saying. And peritoneal metastasis different from other that you may have microscopic spread in the peritoneum in spite of this lesion present. So it is very important to do laparoscopy before going to excision or doing other maybe extensive, more extensive what we are seeing in the imaging. We did several cases of peritoneal miss when you have a single lesion and it's stable for a while. We went and resected this lesion and the patient doing very well after that. Otherwise, for peritoneal metastasis, it is a bit risky to do surgery because you may have more widespread in these cases. Yes.
Regarding the clips which you apply for closure of the mucosal defect after third space endoscopy, including POEM, GPOEM, it usually goes spontaneously after 2 to 4 weeks and no need to be removed by endoscopy because they are small metals. It goes by itself when there is a closure, complete healing of the mucosa. So the clip will dislodge by itself and it goes to the gastrointestinal lumen without any complication usually. But there are some schools they do suturing, endoscopic suturing technique nowadays going more progressive for closure of any hole, any perforation, including after iatrogenic third space endoscopy. They are now doing some school, but it's expensive. Not good hemoclip application, much cheaper and easy for us.
Thank you, Dr. Hiwa, for the wonderful case. I have 2 comments and 1 question. My first comment is GIST tumor nearly never happen in the esophagus because the cell of origin, which is the pacemaker cell of Kayal, is not located at the esophagus. So when you find such lesion, stromal cell tumor, it may be a leiomyoma, and second is schwannoma, or granular cell tumor, or apricot tumor. These are 3 phenomena of the same tumor. The second comment is that leiomyoma and apricot tumor or granular cell tumor more common arise from the second muscularis mucosa layer, not from the fourth muscularis propria layer, opposite to his stomach and the small bowel and rectum. My question is, what is the maximum diameter of tumors that can be removed by self? It is very difficult to resect. You did a very excellent job, but much more difficult is how to extract. Is there a maximum size of the tumor to be removed by stir?
Professor Lingo, who is the author of submucosal tunneling technique textbook, which is a very good book regarding how to do submucosal tunneling technique for various surface procedure, including for esophageal, superficial mucosal lesion, for yeast, for biomyoma. He mentioned that it's better not to remove lesion more than 3.5 centimeter because the technique for removal of the lesion is almost challenging. And they say in this book that even 3.5 to 5 centimeter may be extended criteria, but more than 5 centimeters should not be tried because it will be a big problem for removal of the lesion and there will be more complications. Ideally, for cases who are symptomatic, the lesion between 2 to 3 centimeters may be the best option for doing submucosal tunnel endoscopy resection or point.
Thank you.
Can we hear? We don't hear you.
I have to confess that these speeches were wonderful. They're very thorough, but I had to single out Dr. Nian's presentation as an amazing presentation, very solid, the data very complete. It matches what we have in our practice. Cytoreductive surgery is a very challenging. You need a surgeon that be very patient, that stays in the operating room for hours and hours. You really have to remove, as we say, cytoreductive, cells by cells. It's very successful if you are thorough and use the hypothermic technique, and it's very rewarding. It is very challenging, and if you decide to do one, you make sure that you sleep well the night before the surgery, and you tell the anesthesiologist you're going to be with me for the next 12 to 15 hours. Dr. Makki Hamadi presented a wonderful idea that we have to apply in our country. We have to single out the risk factors of colon cancer. It's very common here, unfortunately. I do want to ask him a question specifically about the relationship with obesity. It seems to be there's a lot of studies coming out showing that obesity is a huge risk for colon cancer. And for staging of pancreatic cancer in the United States, we're becoming more aggressive. It's getting to the point, especially with the face of having immunological treatment, anti-cytokine receptor inhibitors, and we're studying more thoroughly the biology of the disease. Even the cancer, when the first time around comes the second time around, they have biologically different tendency, and the genomic study and biogenomic studies seem to be different. So I think we should encourage having more research, more biology study, more immunotherapy. These seem to be making a difference in outcome for long term. Thank you.
Can I comment on the pancreatic cancer, actually, Asad? Now, the new guidelines for the pancreatic cancer early discovery, early detection, is that especially anyone who is obese and in recent diabetes, after the age of 40, straight away investigate. Start MRI or EUS or both alternative years. Anyone diabetic who start losing control, after straight away investigate for pancreatic cancer. This actually we should, so that they can detect early and treat early. And I think, as you said, there are immunotherapy now. We are having now some cancer of the rectum completely melted on immunotherapy. In the past, we were talking about spontaneous regression of cancer. If anybody of you know this, there was a lot of data about spontaneous regression of cancer. Immunotherapy is one of them, actually. If you have stimulated yourself, then the change of the environment of the cancer, you can have complete cure with this specially immunotherapy. Well, we have seen a few cases lately, complete clearance of the cancer on immunotherapy, nothing else. So I think we are having a time, the future is with us. But for our country, we need data. Number one, the age groups for all the governorates. Number two, the genetic background. I'm just telling you now, how many Lynch syndrome we have in this country? How many Lynch and Suleimania? You know Lynch syndrome, we have 2 generations, multiple cancers in the breast, the colon, and the pancreas. How many? I'm now following about 40 cases of Lynch in one Abu Dhabi. And many FAB, we have about 4 or 5 FABs. How many of them you have in this country? Anybody doing genetic test here? In Qatar, by the way, they did all the Qatari genetic, yes?
Yes.
They did all the genes for the Qataris. They've all the genes. Now they are studying in Abu Dhabi, actually. Is it difficult for Iraq to do it, this country? When I said about the pollution, I wanted from US and UK to do this for us. Bring this know-how and the new labs, do all the genetics in our area, and not only the genes, but the new, what happened to the gene aberrations. The change in the genes, the P10 was not coming to us here. P10 gene is the suppressor gene. We sometimes use it in MS, in Cowden disease, but we have seen it in cancers of the colon and the breast. So this area and research that we should initiate actually. From this meeting, we should make a recommendation, Muhammad, from this meeting. One of the recommendations is to have the whole country, take the all average group, start at the age of 40, and check the genetics. Thank you very much. Please. Madhkur. Better with a microphone.
So, very nice case, Dr. Hiwa. I have one question and one comment. Sometimes it's difficult to cut the leiomyoma. Sometimes it's difficult to cut the leiomyoma into many pieces. So you use special current while you're cutting it to 2 pieces or not. The other point is the small
pure cut for
use pure
after extraction.
Okay. The other point is small comment. Professor Lingo, who actually is my mentor, so I'm happy you mentioned his book. I stay in his center 6 months. What you say is totally right, but we have some important points. The location of the lesion. So actually, when it's near the cardia, usually its shape is irregular, like a dragon with 2 or 3 heads. So it's difficult to extract even or cut inside this narrow space. And the other treatment option is distal esophagectomy and the gastric pull-up, which is not very invasive. But when we are in upper or middle esophagus, it depends on the shape of the lesion. So we can resect a lesion like this, or maybe 7 centimeters if it's like a banana. Like when we do ERCP, sometimes you see stones. One stone is like 3 centimeters, and you can extract with balloon after balloon dilatation, because its longitudinal axis is 7 centimeters, but it's not. So it will depend on the shape of the lesion and the location. If it's distal, maybe this is right, because usually it will be irregular, and the surgical option is easy, but it's more proximal. The surgical option is very invasive and very aggressive, and according to the shape, you can remove lesion like this. I think you do, it's about the end, it's no complication and minimally invasive, but you should be sure it's a leiomyoma. So if you are sure, it's no problem to cut on 2 or 3 pieces to get it out.
Yes, thank you.
Victor, and one question just before going. About short course and long course chemoradiotherapy. Do you believe in that? Because you present one that they are similar. We never use short course in our center, always the long course, because we believe that is more complete pathological remission with the long course chemoradiotherapy. And the short course is much better, especially if you have a long waiting list. It is only 5 days and will be very helpful.
Thank you, Dr. Kakel. Previously, they are using short course radiotherapy 5 in 5, then doing surgery within 1 week.
Yeah.
But nowadays, in the TNT trial, they are using short course, then giving chemotherapy, either 6 course of Capox or 9 course of Folfox, to be followed by surgery. The long interval between the radiation and the surgery increased the rate of pathological fracture. And in some study, they say the more course of chemo also has effect on the rate of the pathological complete response. The meta-analysis of all the randomized and non-randomized trial in comparison between the short course and long course, there is no difference in the overall survival and the local control. Really, it is good news for our patient and for ourselves because we have a long waiting list. And also in the trial of TNT, it is also good news because the disease-free survival is better in the TNT trial comparing with the standard long-course chemo-RT.
Okay.
Okay.
Thank you. Thank you. Okay.
Dr. Ismail.
لا.
Have you any experience or any idea about preparing patients for renal transplantation to do for them colonoscopy as a preoperative preparation? As a preoperative preparations for those who are going to undergo renal transplantations, do you advise them to have a routine colonoscopy preoperatively or not?
I think for the colonoscopy, we know the risk factors for colon cancer now. We know it's the familial, congenital, and the environmental, and of course the associated comorbidities. One of them is immune suppression. Anybody with immune suppression, even hepatitis B, are liable for more cancer of the liver or colon. You know this, yes? So any immune suppression by renal or by dialysis, they are more susceptible to Kaposi sarcoma, lymphomas, and cancer colon. So they should all be routinely checked. And by the way, anyone with breast cancer should be checked for colon cancer because they have the same gene. So somebody with a breast cancer.
No age limit?
Sorry?
No age limit, age of the patient?
The age would depend on, we said, ordinary population, 40. Those who have special things like genetics depend on the gene. 5 test addition of 10. Lynch, go 25. Those with immune suppression depend on immune status. We have seen in our practice actually many cancers in IBD patients. We give immune suppression, steroid, Imiran, and of course the biologics. We have seen many cancers, thyroid cancer, brain cancer, etc., and also colon cancers. So it depends on the family background and the degree of immune suppression.
So you advise?
We strongly suggest before any transplant you should do it, and at the same time when you have immune suppression you do it. And your age, of course, and all of you above 40 should be screened for at least the fit test for the stool or colonoscopy or both. But if a family history, there's no way. You should go to colonoscopy because you cannot detect colon polyp by fit test.
By the way, the risk of obesity is increasing, and it is a risk factor for renal cell carcinoma as well, not only for colonic cancer.
Definitely.
There's the spontaneous regression is happening in the renal cell carcinoma and malignant melanoma as well. And my next question is Dr. Hiwa. What's the difference if you just resect without doing a subtunnel? There is any change regarding the morbidity of these cases?
You mean endoscopic resection?
Yes.
We cannot do endoscopic resection for lesion arising from the muscularis propria.
No, in this particular case, because you see that the mucosa is so stretching, the tumor is stretching the mucosa, and you can easily resect it without doing such a tunnel, and probably it will be very rapid and more faster than doing such a tunnel.
Without
the difference between this and that?
Yes, without tunneling technique, it is impossible to remove this lesion safely because you open mediastinum and the patient will
you don't open because the mucosa is already stretched. Yeah, and you can do such a space between your mucosa and the submucosa. You can resect mucosa all with that of the tumor without making a tunnel.
Yes, the lesion arising from muscularis propria.
I know.
We have to make a complete excision.
Yeah, you get my point. No. When you are going to resect this, you are doing QRP. We are doing HOLIP. HOLIP is you do a resection of the prostate from the capsule. It's the same idea. You know, anybody here, you have got any experience regarding the resection, whole prostate can be resected. And then we do morcellation for the prostate inside the bladder. This is a resection. You can easily, if you have a great experience, you can easily resect away from the wall of the esophagus without doing a tunnel, without so much time, and you can just easily resect with the mucosa. That's my. Yeah, the roofing. You can. Oh.
Yes, but we have to close. Then we cannot close the defect area, which is very big.
No, it's a mucosa.
No, because the lesion arising from the muscularis propria.
I know, but you are resecting the mucosa.
We can remove.
If you go back to the
intramucosal cancer by this technique.
دكتور اسماعيل تو تبي ميوكوزاكا او بريد اللي بيني
لا الميوكوزاكا شيء اللي قلبه
يا اخي شلون ميوكوزاكا
يا اخوي ميوكوزاكا يقلبه كاكا
we do
دكتور اسماعيل لبروي لمصله هذا it's arising from the muscle
we are doing full we are doing full thickness resection during third space endoscopy. We are doing perforation of the muscle. We are making perforation in the muscle, and we are sometimes during POEM we do complete myotomy, so we cut the muscle, and we because adventitia of the esophagus is very thin membrane, cannot protect the esophagus from separation of the mediastinum or to the intraluminal content. So if you don't protect the mucosa from the adventitia, there will be mediastinitis, and the food will go into the mediastinum directly.
Thank you so much for all audience and for our presenters. Now we have 20 minutes only for
15,
the coffee break.
Just 15 because we are lacking
15?
time. Yes.
Okay, it is only
Come
15
back
minutes.
because the last part will be very interesting. We have a workshop. All of you are involved for the panel of liver transplantation. So please take your coffee and come back soon. Thank you.